Other charged words to kind of avoid with folks that can really, especially someone with trauma, that can really kind of trigger a difficult episode. I see you refuse to get that UA or whatever it is, right? Refused is a word that's very charged and doesn't have a negative connotation. So think about like a family member or guardian or something reading this charge. To me, that just sounds so negative. They refused. What is something else we can say?
Declined.
Declined. Chose not to. Right? And non-compliant. How many still use it? Oh, come on. Be honest. We shouldn't be. Why? Why do you think that word is not trauma informed? What are they not compliant to? What I want them to do? So what? That's their choice. So how do you talk to each other when your clients aren't around? You know what I'm talking about, right? A lot of sarcasm, a lot of humor, because we kind of try to keep, right? But I'm telling you right now, you guys, we shouldn't do that. We can't do that. If you need to blow off some steam, have one person that you absolutely trust and you can, get that out and they won't jump on the bandwagon with you and just start. Oh, it's a clinical consultation. Really? It sounds like gossip to me. When you've sat, what's your name? Me? And yeah, that's Susan. Say, Susan and I have sat for the last hour complaining about, Amy who's coming in. Oh my gosh, have you ever heard of it? I don't. How are you going to feel when you walk into that meeting? You've already set your tone to this negativity and to less than respectful. It affects the outcome of services. Instead of doing that clinical consultation that turns to gossip, and thinking, oh my gosh, here comes this person. What if you were to think of that as, wow, here comes one of the best teachers in life. What can I learn from this personality? Think about how you refer to the people that you're serving, even when they're not around. I would not like to know that these folks are sitting there complaining about me for an hour before I come in and get my treatment. It doesn't feel good. What can we do to be more prepared, more trauma-informed? Know your clients' histories. Are you guys pretty well versed in your client stories and histories? Do you have a lot of cold calls or anything like that you do? Or is it more these are people that are on their caseload and you know them? Do you know about trauma history and all the people that you serve? No. Nope. Find out. And I'm not saying to try to pull, what's your name? Amanda. Sit down with Amanda and try to pull out all these nasty details of the trauma in her life. But talk to me about your experiences and how that's affected you. And then it's our job to turn around and help Amanda figure out why every choice after that is tied to that trauma. That we have to break that cycle. We're pretty intuitive people, caregivers, right? You can kind of feel when you walk into a room. What does it feel like? Is it kind of tense? Is it kind of cash? Is it kind of judgy? Be sensitive to that. Use your observational skill. And be prepared and ready for anything, because if someone does start to share with you, we can go right back here. That's when before you even ask about trauma history, make sure you're in that place where you already hope to bring the energy down, bring it from here to here. When you see it going back to the amygdala, take a breath, ring the bell, whatever works for that person. I have a client that, we just have a little bell and they'll ding it when they need a moment. Let's talk about being healthy, trauma-informed staff. First, we're going to watch our language, right? Even behind closed doors. We already talked about that. And we're going to really try to reinterpret the difficult behavior or what looks to us like manipulation, attention-seeking, avoidance. We're going to reinterpret that through the lens of trauma exposure now. Now that you're understanding that when someone is just not getting it and not wanting to move on, they're still stuck here. We got to get out of the reptilian brain. We need to avoid overreacting, underreacting. Especially if you've asked someone to share a trauma history and then you go, oh my God. You're not going to do that, right? And then power struggles. The bane of all of our existence in life, right? Let alone, and not just at work. Getting into those power struggles. Don't bite. Just don't bite. Don't take the bait. What's the best way to react with someone who is just pushing every button, using that manipulation in an unhealthy way, right? And trying to get you engaged in this thing? What's the best reaction?
No reaction.
No, you still validate that you've heard them. You validate the feeling, right? But you don't, you say, well, we need to move on. You just disconnect. And it's so hard when they're right there with you, right? It sounds so easy, but it's hard. If you happen to see a coworker in a situation, here's the other thing for healthy trauma staff. If you happen to see a coworker who's got sucked in, and they're trying to win this thing, right? Yeah, you can do it. We've all been there. We need to give each other permission. In order to be healthy, trauma-informed care staff, give each other permission and tap each other out, right? Have some sort of code word, something. If you're working with someone and you see that this is just going from bad to worse and the energy's going up, hey, you've got a phone call in the office. Help them to step away. Best thing is if you can recognize when your amygdala is going off. Okay? Give yourself permission to say, hey, I need a moment. Step out, take your breath, roll your eyes, whatever you need to do just to get it out. But don't get sucked in. Our job is to find the distress, right? The underlying need. So much of the time we're dealing with this issue or that issue or, all the practical kind of stuff. And then we're trying to deal with this behavior that's right in front of us, rather than trying to figure out what's underneath it. And if we focus a little bit more on what's underneath the behavior or the verbalizations that you're getting that don't really match, is it fear? Is it distress? Is it mistrust? And then work on that feeling. How do I lend a sense of safety? How can I help lend a sense of control? This is big. Open up communication. If I go into a job and I don't know what's expected of me, then I'm kind of flailing. I'm just kind of doing this and my wheels are turning, right? It's the same thing in treatment. What's the expectation? Make sure the person you're serving understands the plan, what's expected of them for next time, what's expected in the long term. The fewer surprises for someone with a trauma brain, the better. Explanation, education, communication, open. Really helps. Not a lot of surprises. And like I said, I tell my nurses, basically to focus on customer service when you're meeting those needs. Remember, respect. So in this section, let's talk a little bit about what can we do to keep from getting to a crisis point ourselves and our clients? How do we prepare for that? What can I do in these situations? And as a professional, what's the main goal? I've already said that several times. It's to take energy away. First thing, like I said, easiest thing we can do is listen. Use our ears. Listen to the story. Validate the feelings. And then try to identify that underlying need. And focus on meeting the need. Not necessarily changing that behavior in the moment. And offer something, anything that's meaningful, as an alternative to this person kind of amygdalaing out, making up my own words. Offer something as a distraction that will bring them back. Whether it's, hey, let's go get a candy bar from the machine, a cup of coffee, the tea, hopefully something healthy. I'm naming all these things that I'm craving, I think, right now. but something that's meaningful to them to kind of bring them out of this amygdala, okay? So think about some of the things that are, I know trigger is kind of a funny word, some of the things that could get someone into an uncomfortable situation. Because the best chance we have to de-escalate a situation that's happening is right at that point. We've got to recognize what's setting that person off, right? What are some of the things that you see that really set off some of the folks that you're working with? Crowds? That crowding?
Law enforcement?
Yeah. 0 to 60, right? I speak to a lot of police departments as well. And one of the things that was really eye-opening for them when we talked about this in trauma and people on the street was that understanding a little bit about what's happening. They're not ignoring you. They're not purposely trying to be difficult when a police officer is shouting maybe do this, do that. What's happening, remember? Are they thinking very clearly in that crisis situation? No. They are just focused on all they see is the threat. They may not even hear the words. And the police officers don't work under the same set of rules that we do. There's a safety first no matter what. We gotta, right? Crack down. But if we can work with the police department that we work with and help them to understand what's going on here, and instead of running in with all this energy and bringing it up so the amygdala's even going off more, then we could have a whole different outcome. Once you do the 911 thing, once you call the police in, you've given up all your rights to handle that situation. So make sure you really need the police, because that's just it's going to go straight to crisis. You know, we talked about environmental things as triggers, dates, right? Anniversaries of trauma. If you know your person's story, and you know that every year around November, man, this keeps happening. There's this cycle right here. Why? Do a little detective work. What's the trauma that triggers that? And how do we help them to expect something different next year? Times a day, do you see a difference when you're talking with people, even the people you're working with? But especially with someone who's got a trauma brain going on, different times a day are very difficult. Sometimes for everybody it's different, but different times a day are difficult. In the inpatient setting, the worst times a day are change of shift. Most incidents occur then. You know why? Anybody? Huh? It's a big change. But also, someone with the amygdala going off is thinking, they're talking all about me. Knowing what they're saying. Already getting defensive for the next shift to come in, right? And needs aren't being met very well, because it's usually not enough staff on the floor while everybody's doing shift change. So just looking at this crisis cycle, and you can help your local police and the people you work with understand this too. So we have our triggering event, right? And during the escalation phase, if you know your client, you'll know when their amygdala is going off. If you know them well enough, look for the signs. The minute you see that change from baseline, you need to intervene. Again, with that distraction, somehow bringing them from here to here, okay? So you have to be very observant and very aware of your client's signs so that you can intervene right away. Crisis may just be, they end up yelling and they are coming back down. But remember, the higher they're going in this crisis cycle, not thinking clearly. So we're not going to be doing any deep therapy if someone's got their amygdala going, because it's not going to work. It's only going to frustrate. So not even to process that information. The kind of communication we use here is crisis communication. If someone's in that crisis, that amygdala is going off, crisis communication, of course, is short, simple, repetitive, use their name. Right? Amanda, I see that you need to feel safe. What can I do to help you feel safe? Amanda, you're okay. You know, just over and over and over again until you can get someone back to baseline. And then there's always post-crisis depression if you work in a facility or if you're going to a shelter where you're meeting someone. Maybe they had a difficult day. They kind of had an amygdala day. They got in trouble, whatever for it. And there, you might meet them in this phase, post-crisis depression. What happens after someone is got all crisis down, and maybe did something not okay, you know, threw a chair at somebody, whatever it is. What happens when they come back down, right? Post-crisis depression. They're gonna feel, what kind of feelings are going on there?
Shame, guilt.
Shame, guilt, doubting themselves. So what can,
back to that hopelessness.
hopelessness again. And what do you have to watch out for here? So if you come in at this stage, if you're coming to have your meeting with them after something like this has happened, how good is therapy going to be? No. You need to let them process a little bit. And we also need to keep an eye on these folks at that time. That's the highest rate of self-harm at that point in the crisis cycle.
What do you do with the ones that are on drugs? When they tell you that they're like addicted to heroin or meth, and they're having these mental issues on top of that?
What do you do?
What's the suggestion? You
That's,
suspect it?
you know, the thing is, what do you do if someone doesn't want to stop taking their drugs? You can't, there's nothing you can do, right? You can educate. You can talk about how they're throwing a whole other chemical component into what's happening biologically. It is not helping. It may feel like it in the moment, it's numbing, but in the long term, that's never going to make it go away. These are brain changes that we need to be able to clearly talk about and work on the kinds of interventions that you need to do. Again, it's over and over again trying to educate and communicate and help them understand how detrimental that self-medicating is. They're just perpetuating the cycle.
Do you think harm reduction works best in that situation?
Yeah. That's about all you can do, is basically the basics. Help them survive at that point until they're ready to change that behavior. Some of the things to really remember about the people that we serve, you guys, and trauma. And the people that we serve are doing the very best they can, given the environments and culture that we create around them. A lot of it's on us. Remember also, perception is key with trauma. Perception is very skewed. And our actions or words can be completely misunderstood. We need to have a very high level of respect, because look at how far people have made it with the just survival skills. Embrace this kind of trauma aspect into our treatment. Not only does it make work more pleasant between us coworkers, job satisfaction, it feels better. You create an environment that is trauma-informed from one another. And you're going to see a lot more growth. You're going to see a faster recovery in the people that you're serving. If you get up in the morning and you come to work and you think, how can I not traumatize somebody today? What am I going to do today to make sure I have my self-check system? I'm not going to go there. It just makes life more fun.
In a lot of our care, whether it's mental health or whether it's the BHCC office or housing case management, we always have these plans that we do with people. Would you say, one of the things we can do is keep it very simple and not have too many tasks and goals and priorities, and just keep it very simplistic so that people can manage it and not feel overwhelmed, which might lead to more.
Not only, very good point, not only do you need to keep your treatment goals and treatment plans very simple, let's work on basic need stuff and work our way up. Not only does it need to be very simple, concise and understandable and achievable, right? You always want to help with achievable goals. And I'm talking about this week, maybe you'll walk outside your door twice. Yeah. Goal reached. Big darn deal about it. Not only does it need to be simple that way, really bring it down a little bit. You want to set people up for success, right? You can't help that by really working on this part of the brain. Having them do activities between the time that you meet that are going to really work that part of the brain. Have them read a paragraph, an article, something. Have them really put thought into it, right? Something that you have them read that you want some feedback on the next time.
I always try to start off with encouragement. words of encouragement to start off. And sometimes when you do that, they give you a key word to how they're feeling and what's going on at the time. If you listen to what they're saying, sometimes it will tell you exactly what their problem is.
The clue is right there in that conversation, huh?
Yeah. I mean, that's up to you. And some people, I've seen a lot of people deal with it and they miss it altogether, and it goes right past them.
You know why? Because we've been doing this too long. You might be a little burnt out, you might be a little numb. You're not present. You're not present. Ground yourself before you walk in and try to do work with someone, because you're gonna miss those cues. Of that is a struggle just to get through the day. Let alone if you had the thought disorder or voices, that kind of thing. Think it, remember that, understand that the brain is really working in a very different way. And take care of you, you guys. I just can't emphasize that enough. Caregivers are the worst. People in this business are the worst at taking care of themselves. You're just going to see a huge difference if you're more balanced coming in. And remember, you're being watched very closely for social cues and things. So if we're coming off closed and kind of angry, we're not getting anywhere. A lot of it's simple stuff, but just imagine, and it's stuff you know, but now you know how much bigger it is for someone with trauma. It's very overwhelming. Pebble versus boulder. Remember that for perception. Any other questions? Yeah.
What message are we giving with the size? I have a family member that I have breathing issues if I go upstairs, and I just have to stay outside the door until my breathing is normal because he takes it.
Takes it.
Time.
Do you know what I think it is? What do you think it is, guys? How do you feel when someone's doing a lot of?
They don't really care about what's going on. They don't really care about you.
I so don't want to be here right now.
Hurry up and get this over with.
Let's just move this along.
I'm one of those who sigh every reason.
Mhm.
And if I know you really well, I look at you and say, no, I can sigh or I can fart, what do you want? You quite so well. I let them know that this is not.
Pick your poison.
This is just
I'm good
me.
at that.
I'm not upset with you, I'm not impatient, this is just me.
And that's great. It was clear communication. And that's why if you know how you're perceived, if you know how you're kind of coming off, see, it's a good that someone gave you that feedback, right? Now, it doesn't mean we have to stop doing that. You just know that you have to get my breathing under control before I go and say, I'm rolling, the body language.